You've mentioned transdermal estrogens, but I'm aware that there are different formulations available, patches and gel and so forth. How do you choose?
There are three main different types of transdermal estrogen. We've got the patches, we've got gels, and we've got a spray. And they all offer pros and cons, as you'd expect. And it's a very personal choice for a woman as to which one is going to best suit her. So if we take the patches to start off with, the patches can be very convenient. You stick them on, you leave them on for 3 to 4 days, and you change it. So you don't have to think about your estrogen replacement in between those times. So you might change your patch on a Monday and a Thursday, for example. So very convenient. They also have the benefit of releasing the estrogen in a constant way throughout a 24-hour period. So they can be very useful for women who have been suffering an increase in migraines or headaches during their perimenopause, because it smooths out the peaks and troughs of their hormone. The downside is that once we've prescribed a particular strength of estrogen patch, then there's little flexibility to go up and down around that. And certainly when a woman first starts her estrogen replacement, it often takes a little while to find the right dose for her. So we don't have dosing flexibility. But as an offer, once somebody's stabilized their dose and they know what works for them, then the patches can work very well. Another downside of the patch is that for women with a very active lifestyle who might be swimming a lot or taking long baths or sweating a lot in the gym, then they can fall off. And for some women, they get irritation from the adhesive. So there can be downsides to the patch. There is also a patch that contains progestogen, which can be helpful for women who might have some compliance issues about taking the sort of micronized progesterone that is part of an HRT regime. That's the patches. The gel is very flexible. So in the way that the patches are not flexible from dosing, gels are, and they come in either sachets or in a pump dispenser, and you apply the gel daily. So what you would do is get into a routine that works well for you, maybe a shower in the morning, dry your skin very well, and then a couple of pumps of the gel, one on the inside of each thigh, spread over a large surface area, let it dry and get dressed. Very straightforward, very flexible in dosing. You can go up and down straightforwardly. The downside for the gels that women complain about is that if you're very busy and you're not, you're rushing around in the morning, you probably don't want to wait for your gel to dry. And if you're applying as many as 4 or 5 pumps, which can be possible, particularly for our perimenopausal women, you do feel you're rather covered in gel and getting cold in the winter if you're waiting for it to dry. Having said that, again, if you're organised, get yourself into a routine, you can pop your underwear on, pop your gel on, then do all your makeup and your hair and any other bits and bobs that you do as part of your getting ready routine, and it dries in about 5 minutes. So that's the gel. And then the other formulation is a spray. The spray's, again, very flexible. The spray can be very useful because it dries more quickly than the gel. If you're using a lot more estrogen in terms of your body needs it from an absorption point of view, if you're using more than 3 or 4 sprays, you can run out quite quickly. So it's not as you can rush through your pumps quite quickly, and if you're buying it privately, that can work out a little bit more expensive. I personally like the spray. For me, that works because I'm not touching it. And that's important for me because I am doing hormonal blood tests on women and I don't want to contaminate the site at all. So even though I wear gloves when I do the blood draw, when I'm feeling for a vein, then I'm using my finger. I don't want to be in any situation where I could have potentially got hormone to contaminate their site. So for me personally, spraying it, I don't have to touch it. So it works very well. So those are the 3 main formulations of estrogen that are transdermal.
Very useful. Now, you also mentioned genitourinary syndrome of menopause, GSM. Can you tell us a bit more about that?
Yes, so genital urinary syndrome of the menopause happens to most of us actually, about 70% of women post-menopause will experience symptoms in the genital urinary area. And this can range from weaker bladders, so leakage, incontinence, our pelvic floor muscles, relax, notwithstanding any, issues that we might have had during childbirth. We can be prone to more urinary tract infections because the flora in that area changes, more cystitis. And of course, we can, it used to be called vaginal atrophy, but it sort of explains very nicely, or not so nicely, what's happening to the tissues of the vagina and vulva as we age. So in the same way that we lose collagen and flexibility in our skin, which we spend a lot of money and time on moisturizers and looking after, the skin in our vulva and vagina also declines, becomes thinner. In fact, it can become so thin that women can be prone to bleeding, can get very, very sore. Sexual intercourse becomes incredibly painful, if not impossible, and they can be prone to vaginal infections such as thrush. And of course, it's an area that women either accept because, oh, I'm getting older, or they're not really thinking about because maybe they're not as sexually active as they were, or they're just putting it down to old age. And sadly, we have, residential care homes full of older women who didn't have HRT, have not been supported in this way, and they're getting recurrent urinary tract infections, which are incredibly dangerous for them as they get older in terms of acute kidney injury. So this isn't just a touch of sorting out your dry fanny. This is about making sure that you keep yourself as healthy as you possibly can. It's super easy to fix. Systemic HRT that we've talked about, so the topical transdermal estrogens, will help enormously. But actually, what many women find is that they need local estrogen. So that would be either a cream application, a pessary that they can use and leave in for 3 months, or vaginal pessaries that you insert. And that will release estrogen into the area. It's a very, very tiny amount. If you lined up all your vaginal pessaries for the year, it would probably be equivalent to 1 contraceptive pill in terms of estrogen enclosed. So very effective, and it can change, again, the cells of the vagina and vulva. It has a local effect on the urethra and the area around the bladder. It can tone up the pelvic floor, although we still need to do our pelvic floor exercises, of course, and generally improve the symptoms. And we've seen a lot of women who've had significant life-changing, women that have been nervous to go out because they'll pee themselves or they have to know exactly where their loo is. And just simply replacing their estrogen has been enough to address the symptoms. Very important, not talked about enough. And women with a history of breast cancer can use these pessaries because the level is so low. So sometimes a woman with a history of breast cancer who can't use systemic HRT can at least have her GSM sorted out.